Welcome to the Deep Dive. Today, we're tackling, well, a really complex and often misunderstood topic, dissociative disorders.
Hmm.
And this deep dive is actually shaped by you, specifically from the revision notes you've gathered, possibly for something like the MSRA.
That's right. Our goal here is to, work through that material together.
Yeah, pull out the high-yield stuff, make it clear, make it stick, whether you're deep in revision or just aiming to get properly informed.
Exactly. We'll look at the definitions, causes, symptoms, diagnosis, treatment, the whole picture presented in these notes.
Okay, brilliant. Let's just dive straight in then. According to these notes, what exactly are we talking about with dissociative disorders?
So fundamentally, they're a group of mental health conditions where there's some kind of breakdown or disruption in the normal integration of consciousness, memory, identity, even perception.
A disruption, like things that should be connected aren't.
Precisely. It often results from significant trauma or stress causing a sort of detachment. The notes highlight that this exists on a spectrum. So you might see, say, milder dissociation in something like PTSD, all the way up to the more severe end, like dissociative identity disorder, DID.
And the notes gave other specific examples too, right?
Yes, dissociative amnesia, where memory loss is the main feature, and depersonalisation, derealisation disorder. That's about feeling detached, either from yourself or from the world around you, feeling unreal.
Gotcha.
And across the board, these notes point to things like memory problems that don't quite match the emotions tied to them, a kind of fragmented sense of self, and specifically with DID, those distinct personality states and significant memory gaps.
Right.
A really key point the notes make, though, is that these conditions are often hidden. There's shame, maybe fear, so how they actually look can vary wildly. But that concealment seems crucial.
Yeah, that hidden aspect makes understanding and diagnosis really challenging, doesn't it?
Absolutely.
So if trauma is often the trigger, let's talk etiology, the why. Why does trauma lead to this sort of disconnection for some people?
Well, the notes are pretty direct here. They point primarily to significant psychological trauma, especially when it happens during childhood, those critical developmental years.
Okay.
The thinking is the trauma is just too overwhelming for the person's normal coping mechanisms. So dissociation kind of kicks in automatically. It's a way to mentally escape something unbearable.
A survival strategy, essentially, when you can't physically get away.
Exactly. It's a coping mechanism born out of necessity. But the notes also add it's not just the trauma. Yeah, things like inherent personality factors or maybe some neurobiological vulnerabilities might make someone more likely to go down that dissociative route when faced with trauma.
Right, so it's a mix of the external event and maybe internal predispositions.
Yeah.
So who's most at risk then? What are the key risk factors listed in the notes?
Okay, the notes lay out several important ones. First, severe childhood trauma or neglect. That's a big one.
Mm-hmm.
Then, repeated traumatic experiences, not just a single event. Also, trauma starting at a very young age seems particularly impactful.
Early onset.
Yes. And critically, a lack of a supportive social network, not having that buffer during or after.
That makes a huge difference.
It really does. And finally, the notes mention individual factors, again, certain personality traits, a history of other mental health issues, or even a family history of dissociative disorders.
Wow. It really highlights the profound impact of early life experiences and, well, the environment, doesn't it?
It absolutely does. It underscores how vital that safety and support really are for development.
Okay, so moving from the why to maybe the how, the pathophysiology, what do the notes suggest is actually happening biologically in the brain or body?
Well, the notes talk about disruptions in how the brain processes information. So things like memory, attention, perception, and just integrating conscious experience aren't working smoothly. When trauma occurs, it activates the body's stress response systems. The notes mention the HPA axis and neurotransmitters.
Right, the stress hormones and chemicals.
Exactly. And it's thought that these neurobiological changes, this kind of stress overdrive, contributes directly to that fragmentation of consciousness and memory that we see in these disorders.
So the biological stress response itself plays a part in the dissociation.
That seems to be the link the notes are making.
Yeah.
Which brings up the question, how do these biological changes actually show up? What does it look like for the person experiencing it?
Yeah, the clinical features. What are the common symptoms described in the notes?
There are several key ones listed. Recurrent memory gaps, often for really important personal details or traumatic events. That's the amnesia part.
Mm-hmm.
Then there's identity confusion, or even the presence of distinct separate identity states, which is the hallmark of DID.
Right.
Also, persistent feelings of detachment. That could be feeling detached from your own body, thoughts, or feelings, like depersonalization, or feeling like the world around you is unreal, or foggy derealisation.
Okay, so detachment from self or surroundings.
Yes. And the notes give examples like difficulty recalling things that happened, feeling like you're watching yourself from outside your body, or
Wow.
just feeling disconnected from your own physical sensations. There can also be noticeable shifts in behavior, mood, or self-perception. And importantly, stress or trauma reminders can often trigger or worsen these symptoms.
Some of those descriptions, like watching yourself from outside, sound incredibly disorienting. I can definitely see why diagnosis would be tricky, given how, well, unusual some of these might seem.
It is very challenging. And that leads right into the differential diagnosis section in the notes. What else could it be mistaken for?
Good point. What does it list?
The notes mention PTSD, borderline personality disorder, BPD, somatic symptom disorder, and they also list malingering and factitious disorder where illness is intentionally feigned.
Okay, so a range of things.
Yes, but the notes specifically call out the difficulty with DID. It's apparently often misdiagnosed as schizophrenia, other psychotic disorders, mood disorders like depression or bipolar, substance abuse issues, or very commonly, other personality disorders, especially BPD.
Why the confusion, particularly with things like schizophrenia or BPD? Is it overlapping symptoms?
It seems so.
Hmm?
Perhaps the identity confusion or maybe internal experiences that get described, like voices, which might be internal dialogue between parts in DID, or the feelings of unreality could, superficially resemble psychotic symptoms, or the instability seen in BPD. The notes really stress this misdiagnosis issue for DID.
It really underscores the need for specialized assessment, doesn't it?
Absolutely. Which brings us to epidemiology. How common are these conditions, according to the notes, particularly in the UK?
Right. What they say.
Well, interestingly, the notes state the overall prevalence isn't well established. They suggest this is partly due to underdiagnosis.
Ah, linking back to the diagnostic challenges.
Exactly. For DID specifically, though, they give a prevalence range between 0.1% and 1%. But the source finishes by saying, quite clearly, further research needed.
So still quite a bit of uncertainty there.
Definitely seems that way.
Okay, here's where it gets really interesting for me.
Yeah.
If diagnosis is tough, but there are tools, why is the prevalence still so unclear? And why the continued misdiagnosis, especially for DID?
That's the million-dollar question, isn't it? The notes do outline a pretty thorough investigation process. It should be done by mental health professionals, involving detailed histories, psychiatric interviews, psychological assessments. They also mention collaborating with other doctors to rule out medical or neurological causes for things like memory loss.
So it should be comprehensive. Are there specific tools mentioned for assessment?
Yes. The notes list some standardized questionnaires and interviews. Examples given are the DSM, Dissociative Experiences Scale, the SDQ-20, Somatoform Dissociation Questionnaire, and the SCIDD, Structured Clinical Interview for DSM Dissociative Disorders.
Okay, so there are structured ways to assess.
There are, but, and this is crucial, the notes heavily emphasize the need for trust. Creating a safe space is paramount, because people won't share these often frightening or confusing experiences otherwise.
Makes sense.
But even with these tools and approaches, the notes repeat that many people with DD still don't get the right diagnosis. And the reason given is skepticism among some clinicians.
Skepticism. Wow, so that's a major hurdle identified in the source material itself.
It appears so. A need for more awareness and maybe acceptance within the field.
That's a really significant point from these notes. So, okay, assuming a correct diagnosis is made, how are these conditions managed? What's the treatment approach outlined?
It's described as multidisciplinary. So usually psychotherapy is the main thing, but sometimes medication might be used for specific symptoms like anxiety or depression. Importantly, not for the dissociation itself. And wider support systems are key too.
And the core therapy.
Trauma-focused therapy is highlighted as primary. The notes mention TFCBT, trauma-focused cognitive behavioral therapy, and EMDR, eye movement desensitization and reprocessing as examples.
So really getting at the root trauma.
That seems to be central. The goals listed are about improving symptoms, processing the trauma, building better coping skills, and integrating those fragmented parts of experience and memory. Social support and community resources are also mentioned as important parts of the plan.
Okay. And what about DD specifically? The notes seem to go into more detail there.
They did. It's described as needing long-term psychotherapy, often one-to-one relational therapy, maybe weekly, potentially for 5 years or even longer.
Wow, that's a serious commitment.
It really is. The therapy isn't just one single type. It draws on various techniques. CBT, DBT, EMDR, sensor motor approaches are all mentioned. A key framework discussed is phase-oriented treatment.
Phase-oriented, how does that work?
Typically 3 stages.
Sure.
First, focusing on safety, stability, and building coping skills. You need a solid foundation. Second, carefully working through and processing the traumatic memories. And third, the integration phase, bringing the different parts of the self together more cohesively and helping the person function better in daily life. Addressing things like disorganized attachment patterns from childhood is also part of it.
That sounds incredibly intensive for both the person in therapy and the therapist.
No doubt. The notes mention specific challenges for therapists, complex emotional dynamics like transference and countertransference, and managing boundaries carefully. And they make a really important point. The quality of the relationship between the therapist and the client is a huge predictor of success.
The therapeutic alliance.
Exactly. And a big part of the work involves engaging with the alter personalities.
How is that approached?
The notes describe it as understanding these different states, helping them communicate and cooperate, potentially moving towards integration. They mention structural dissociation theory, this idea of apparently normal personalities, AMPs, handling daily life, and emotional personalities, EPs, holding the trauma. The approach suggested is non-judgmental, affirmative engagement with these parts. The ultimate aim, integration, isn't about getting rid of parts, but helping the disconnected emotions, memories, behaviors, and identity fragments become more connected, more whole. It's described as, yes, long, demanding work, but potentially very rewarding.
That's a really thorough explanation of the complex process. What about the prognosis then? What's the likely outlook based on these notes?
Well, the notes say it varies. Depends on how severe the disorder is, the trauma history, if there are other conditions present, and of course, how effective the treatment is.
So no single answer.
Not really, but the notes are quite positive overall. They state that many people can experience significant improvement in their symptoms and daily functioning with the right kind of comprehensive help. It's seen as a gradual, ongoing recovery process, not an overnight cure.
Okay.
And getting help early with specialized treatment really boosts the chances of a better long-term outcome.
That's encouraging. And on the flip side, what are the risks if these conditions aren't treated? What complications do the notes mention?
The notes list quite a few potential problems. Things like major difficulties in social life and work. Relationships can be really disrupted. There's a higher risk of other mental health issues developing, like depression or anxiety disorders. Self-harm and substance abuse are also noted as significant risks.
Serious consequences.
Yes, and ongoing problems with memory and concentration can really impact daily life. Just basic functioning, maintaining stable relationships, holding a job all become much harder. The notes really hammer home that early recognition and proper management are crucial to prevent or lessen these complications.
Wow. Okay, so we've really covered the ground laid out in these notes. For the basic definition, the trauma connection, the specific symptoms, the challenges around diagnosis.
Right through to the intensive treatment, especially for DID, and the outlook.
It's clear these are complex, serious conditions, often rooted in really difficult experiences, needing specialized care. But importantly, the notes do suggest that recovery and improvement are definitely possible with the right support.
Absolutely. And reflecting on it, that point about underdiagnosis, potentially due to skepticism, combined with how complex the treatment is, it really makes you wonder, doesn't it?
Wonder what?
Well, given how hard these conditions can be to spot and how often they might be missed, what impact could greater public and professional awareness, really reducing the stigma around trauma and dissociation, have on people getting the help they need much earlier?
That's a powerful thought to leave people with, and it ties right back into why understanding the kind of information of these notes is so important.
Exactly. These notes seem like a really solid foundation, especially if you are revising for something like the MSRA.
Definitely. And for anyone doing that kind of revision, resources specifically designed for it can be invaluable. Sites like PassTheMSRA.com.
And FreeMSRA.com could be really useful for practice questions and solidifying this kind of knowledge.
Worth checking out. Well, that brings us to the end of this deep dive, based on your notes on dissociative disorders. We really hope working through it this way has helped clarify things for you.
Yeah, hope it was helpful.
Thanks so much for joining us.